little bit different. This is the last module in the pharmacy curriculum called, class called pharmacotherapy. So they learn all the basic sciences, all the students, and then now to the point they apply the drugs into the treatment of diseases. So this is the last module, and they basically learn about all the cancers, different kind of cancers, and then they learn about the different types of treatments at the end. So, so we're going to start today talk about how to, last couple of weeks talk about treatment of different kind of cancers, like breast cancer, prostates, and now we're wrapping up in terms of how to support these patients when they're going through chemotherapies. And in fact, this is why I get into the treatment of cancer as a profession. I'm an oncology pharmacist, as you guys probably know, because it's such an interesting field that we can do so much for patients who are going through this kind of chemotherapy. And I myself see the evolvement of chemotherapy and also the supporting of these chemotherapy for the last 10 years, especially when my grandma had breast cancer back in the 90s. And I still vividly remember, she puked like mad after she got chemo. But for the last 10 years, our evolvement of actually antiemetics for treatment of chemotherapy is much better. And you can see that if you go to a cancer center today and patients getting treatment for breast cancer, you probably don't see too many women vomit. So, today we'll talk about some of the aspects, and these are the objectives. We'll talk about the terminologies, about different types of chemotherapy-induced nausea vomiting. We'll also talk about who are the patients who are at risk for chemotherapy-induced nausea vomiting. And hopefully, as a pharmacist, when somebody approaches you, you'll be able to recommend some sort of appropriate pharmacological and non-pharmacological treatment for chemotherapy-induced nausea vomiting. So I'm going to start off by presenting a case, and again, this is the way how we do it in medicine and pharmacy. So Kylie Minogue, or KM, is a 41-year-old female. She has stage 2 breast cancer, remember that from your previous lectures, and she's getting first cycle of chemotherapy after her lumpectomy, basically resection of the lump. So she had a history of motion sickness, hyperemesis for pregnancy, well we don't know, but hopefully not. She's not a drinker, and some of the positive of her receptors, which the students would know at that stage. So today, she's actually coming to the cancer center and getting this chemotherapy regimen. The drugs are doxorubicin, cyclophosphamide, and they're repeated every 21 days. So now, as a pharmacist, you got a question from your doctor: what kind of chemotherapy-induced nausea vomiting medicine you should be giving to this patient to prevent Kylie of having nausea? But before that, we'll look into the different types of emesis that the cancer patient can get from chemotherapy. So there are 4 different types. Generally, we categorize them by acute, delayed, anticipatory, and breakthrough. So acute emesis means you get chemotherapy-induced nausea vomiting within 24 hours after you receive chemo. So the first 24 hours post-chemotherapy. Delayed is any time after the 24 hours when patient receives chemotherapy. Anticipatory is before a patient walks into your clinic and she already has this mental image, oh my God, I'm going to throw up. So they anticipate that it may happen. And breakthrough emesis is even though we have provided enough prevention, yet they still throw up or having a nausea or vomiting episode. So these are the terms that we'll be using quite a lot in our discussion today. The pathophysiology of chemo-induced nausea vomiting, you probably learned in your pathophysiology classes. Just to review, again, chemotherapy can hit some of the receptors in your stomach, transmitting neurotransmitter signals to your brain, the chemoreceptor trigger zone, and leading to some impulses that lead to the vomiting center. And as a result, patients are having imagery and signals that they want to vomit. And this is leading to the whole nausea and then the whole vomiting episode. The very basic understanding of chemotherapy-induced nausea vomiting would help you to guide you through why we use different kind of therapies in this setting. So what are some of the risk factors? Who gets chemotherapy-induced nausea vomiting? And a lot of these are actually done, scientists find out from epidemiological studies. So basically compiling data and looking at who are more likely to get this sort of condition. So obviously, the more harsher the chemotherapy regimens, the more likelihood they would get chemotherapy-induced nausea vomiting. And we'll go through some of these regimens later on. Poor control of nausea vomiting during previous cycles of chemotherapy, that's quite obvious. So because if they're not controlled the first time, the second time when they come back, they will have imagery and say, well, quite likely I'll vomit today because of this chemo regimen. So that will increase the risk. Also, some of these are pretty interesting, and you can see my little Lego character here. She's female, young age, she's on a boat, and hopefully she doesn't drink alcohol. But basically, if somebody has a history of motion sickness, or somebody has, you know, hyperemesis because of pregnancy, these things will put her into much risk. And in contrary, actually, for older men who's getting treatment for chemotherapy, you rarely hear that they will have nausea and vomiting. And that's because they have much higher tolerance of alcohol, and their vomiting potential is much less. And radiotherapy actually can also increase the risk because it breaks down a lot of receptors in the gastrointestinal tract and also increase motility of the GI tract. So why do we want to control nausea and vomiting because of chemotherapy? Well, many reasons. We want to relieve the human suffering of chemotherapy-induced nausea and vomiting. That's obvious, especially in my case with my grandmother. We want to promote willingness of patient continue chemotherapy. Again, there's studies showing that, you know, if patients get nausea and vomiting, they literally would stop therapy because they cannot tolerate. We want to prevent them from having conditions such as dehydration and electrolyte imbalances. From your previous lectures on nutrition, again, if these patients get very dehydrated and also they get electrolyte imbalances, that may lead to a lot of issues that they may need to get admitted to a hospital. And of course, to maintain good nutrition status is important in cancer patients. So our principles of managing chemotherapy-induced nausea and vomiting are a couple of principles I've listed here for you. And again, the key is prevention. We want to prevent that happening before, you know, patients actually have to deal with nausea and we treat it. So we also want to prevent dehydration also in that setting because, again, by preventing them having nausea, hopefully they won't vomit. Some principles that you probably know from your PK lessons, the oral and IV antiemetics that we have available have equivalent efficacy. And in fact, if your patients can tolerate oral antiemetics, why give them an IV? You know, it's more expensive, and we want to utilize the GI tract. Some of the principles that you probably have learned already. Use an appropriate antiemetic according to the emetogenicity of the chemotherapy agents. We'll go through that briefly in a little bit. And again, in addition to chemotherapy-induced nausea and vomiting, consider emesis because of other conditions. So let's say your patient just came back from a boat ride and have motion sickness. Next they want to get chemotherapy. Quite likely they may throw up. These are in your handouts, and I'm not going to go through the details, but you probably have seen them in your pharmacology lectures. The different chemotherapy agents are classified by different emetic risks, and this guideline is provided by NCCN, the National Cancer Comprehensive Network. They classify chemotherapies by different emetic risks from 5 to 1. And to give you a better aspect, the agents we were talking about earlier, doxorubicin and cyclophosphamide, are classified as level 5, which is over 90% frequency of emesis. So quite likely, a patient, if they don't get enough coverage for these chemotherapy for emesis, quite likely they will throw up. So some of the treatments that we have available are listed for you, and this is more like a review of these drugs that are available. So the 5-HT3 antagonists, which are the agents that we have, such as ondansetron or brandesitron. We also combine them with corticosteroids, and I'm going to go a little faster because we only have a couple minutes left. I mean, usually this is like an hour lecture. Also the NK1 antagonist, aprepitant.
Why don't we stop right here?
You want to stop right here? Well, I want to end up talking about, So back to our case. So this is a breast cancer case, again, back to our original case with KM, who's a 41-year-old female. So I want you to identify what are the risk factors of this patient may getting emesis. Again, her history of motion sickness, her history of hyperemesis in pregnancy. She never drank alcohol, which I really don't believe, but. And also, she's getting a very high-risk chemotherapy agent that quite likely will put her into risk. So, we didn't get a chance to go through this, but in this setting, we want to use a combination of these 3 agents to treat or to manage her chemotherapy-induced nausea and vomiting. And so the regimen should include these drugs. So I ran out of time, but I pretty much just used one of the lectures I had and just trim it down a little bit, but this is supposed to be like an hour lecture, so.
Right.
Yeah. Any questions?